our next session, New Technology in GI Endoscopy Tips from the Experts. It is my privilege to introduce you Professor Parit Mekaroonkamol. Professor Parit, currently Assistant Professor, a gastroenterologist and advanced endoscopist at the Division of Gastroenterology, Chulalongkorn University and King Chulalongkorn Memorial Hospital. Professor Parit is also currently serves as the Director of Social and Welfare of Gastrointestinal Association of Thailand and Assistant Dean for International Affairs, Chulalongkorn University. Please give a warm welcome to Professor Parit. Thank you.
Thank you very much, Dr. Japan, for the kind introduction. I would also like to thank Professor Ratakorn and ASEAN Gastro Organizing Committee for the kind invitation. We have a symposium on the tips for advances in diagnosis and management of gastroenterological diseases, including the pancreatic cyst management and image-enhanced endoscopy. So I'd like to start off with the first lecture of today with the advances in pancreatic cyst management. As we all know, the rising incidence of pancreatic cystic lesions has been quite a troublesome problem for our GI community for quite some time. And in this epidemiological study, it's not surprising to see that with advanced age, the more we find pancreatic cyst in cross-sectional imaging. It can be up to 5% on those whose age above 70 years old to have pancreatic cyst, and this number can astoundingly go to 25% on those who's older than 90 years old. The incidence of pancreatic cyst, as it's rising rapidly, the concern is that whether these will develop into pancreatic adenocarcinoma, which is a dismal disease with 5-year survival rate of less than 10%. But that survival rate can go up to 80% if we are lucky enough to catch it while it's at stage 1A. The problem is that we cannot really find it at this early stage because we don't have a screening program. Therefore, identifying early treatment and pre-malignant lesions of these pancreatic cysts is the crucial key to improve survival of this morbid disease. There are 3 main pre-malignant lesions for pancreatic cancer. The one that has been well established is pancreatic intraepithelial neoplasia. Unfortunately, this is histological diagnosis only, meaning that we cannot really identify the intraepithelial neoplasia on the imaging studies. So we're left with these pancreatic cystic lesions. Out of the known cystic lesions of the pancreas, the 2 that have been more problematic for us is the MCN, mucinous cystic neoplasm, and IPMN, intraductal papillary mucinous neoplasm. The challenge is that how can we identify that which MCN, which IPMN will turn into pancreatic cancer? We know from this long-term prospective data recently published in Gut that out of all pancreatic cysts that have been incidentally found, up to a quarter of 25% will progress in both size and number, and only 1.3% will actually regress on their own. And multiple efforts have been made to identify which demographic data and which clinical parameters that can help predict the high-risk lesions, including the obesity, the smoking condition, comorbidities such as diabetes, and so on. But none of these have hold enough accuracy for us to identify the high-risk factors. One of the most well-known guidelines that we use nowadays is Fukuoka guidelines that has been well established in terms of certain parameters, including the enhanced intramural nodules, the size of above 3 centimeter dilated pancreatic duct. But none of these parameters are by far from perfect. Out of the 5 current guidelines that we have here, whether it's AGA, ESGE, ACG, or ACR, all say the same thing, that all cystic lesions require surveillance of at least 6 to 24 months interval. The problem is that these recommendations are all in low to moderate quality because there's quite limited data that we have on the progression of these cysts. And when and if these surveillance should discontinue remains largely unknown. The sensitivity, specificity, and accuracy of these methods are not optimal as well. And that's why the traditional risk stratification, whether it's clinical parameters, the size, the EUS parameters, including the intramural nodules, elevated the dilated duct or chemical parameters such as elevated CA19-9 has such certain limitations to them. Hence the topic today of the advances in pancreatic cyst diagnosis. We have recently emerging diagnostic modalities to help us identify these high-risk cysts. I would like to start off with just radiologic studies of radiomics of pancreatic cystic lesions. So what is radiomics? Radiomics is a quantitative imaging that uses machine learning and AI to help us identify what the eyes cannot see. The principle is that the grayscale area that we see on the cross-sectional imaging, whether it's CT scan or MRI, there are certain limitations to it of what the eyes of the expert radiologist can make out of. We use the method of segmentation and features extraction. As you can see on the left-hand side right here, that any one of us can identify the pancreas on the CT scan. But out of these areas of the pancreas, there are a spectrum of the grayscale area on the imaging study. When we have the machine learning identify those mixed heterogeneous areas of the pancreas, we can tease out what are the solid component, what are the cystic component, and what type of cyst they are. And this is a method that calls features extraction. Once these features have been extracted, we use the model construction with artificial intelligence method to do a model analysis. And these models will then be applied to the radiologic diagnosis in conjunction with the expert analysis. This is a nice study that's published earlier this year comparing the radiomic model with the expert radiologist in terms of identifying and categorizing pancreatic cyst. And interestingly, and not so surprisingly, we found that the radiomic model have higher area under the curve and higher accuracy in terms of diagnosing pancreatic cyst. But due to the non-inferiority design of the study, the authors conclude that radiomics-based machine learning achieved at least equivalent performance as an experienced academic radiologist in classifying these pancreatic cysts. And this type of radiomics model have been applied into clinical studies since 2017. Multiple studies have evaluated their accuracy and applicability of CT imaging and MRI imaging. However, there remains a need for protocol standardization because most of these models are in-house developed. So to compare between one model to another from different institutions can be quite a problem because we don't have the gold standards for now. So the method of segmentation and feature extractions and further analysis needs to still be further refined in the future. Next off is the cystic fluid analysis. Traditionally, what we do is to aspirate some of this fluid out and send for CEA, amylase, and cytologies. But as we all know, there are certain limitations of these parameters as well. The standardization of CEA value have been under microscope and scrutiny for quite some time, with limited sensitivity of only 63%. Amylase also has high false positivity, and that can be seen in pseudocysts and also any type of fistulizing disease of the pancreas. Cytology, even though specific, but it has quite a low sensitivity. Intracystic glucose has been gained some traction and interest in the community because it has better accuracy compared to CEA in some studies. And its level of less than 50% has been strongly associated with mucinous neoplasm. And in addition, it is quite cheap and available and easy to test. It can give you a real-time analysis even in the endoscopy room. Intracystic molecular markers are also a new kid on the block. This has been studied for quite some time now, and we have now identified more than 15 genetic mutations that has associated with pancreatic adenocarcinoma. Most famously is KRAS and GNAS gene that has been strongly associated with mucinous neoplasm. 97% of accuracy has been associated with these mutations. And out of the 3% with KRAS negative gene, you can detect the BRAF and MAP2K1 mutation. And fortunately now we have the commercially available next generation sequencing kits that allows the small gene panels to be evaluated in cystic and aspirate. The quantity of the fluid is also not a challenge because you only need 1 cc for these genetic mutation analysis. The problem with the mutation analysis is the cost and availability. So in order for it to be generalized and be used clinically beneficially, this has to be further developed. The intracystic histologic evaluation is something is equally exciting, especially for us endoscopists, because we can actually see what the pathologist can see in vivo real time while we're doing the endoscope. Two of the methods that has been studied so far is in vivo histologic evaluation using the needle-based confocal laser endomicroscopy and through the needle microforceps biopsy. So this is what a confocal laser endoscopy would look like. It creates a real-time pathological diagnosis. It scans the cystic wall and see the lining of the pancreatic cyst that can give you as accurately diagnosis as the pathological cytology. You can see the difference between these two. On the left side is the papillary projection of the IPMN, while the right side is a dark, thick band of mucinous cystic neoplasm. And with these findings, you can give the diagnosis with more than 95% certainty that this is IPMN or MCN. I won't go into the classification of the confocal laser endomicroscopy at this point, but there has been multiple classifications developed in the past decade to increase the accuracy and diagnosis of confocal laser endomicroscopy, as you can see how similarly it reflects on the pathological slides. This is a nice study published in CGH a few years back, comparing between the chemical analysis and laser confocal endomicroscopy. And not so surprisingly, we found that across the board, sensitivity, specificity, accuracy, NPV and PPV, the confocal laser endomicroscopy has higher diagnostic accuracy compared to chemical analysis using the CEA alone. What about if we combine that with the FNB? Even if we can get the part of the epithelial lining of the cyst compared with the confocal laser endomicroscopy, we also found that in this meta-analysis of over 2,000 patients, that the diagnostic yield of confocal is actually higher than FNB. And that's partly because on the FNB, you can actually get a fraction of a sample of the cystic wall, while confocal, you can see the entire cystic wall at once. And the problem with confocal is that it can be subjective, as you know, the part of the accuracy of this modality largely depends on the operator. You can see that there can be the clump, the lining, the papillary projection depends on our eyes to see what are the lining and these cells look like. So the future direction of the confocal is probably not going to be the availability of the kit or the technology of the needle probe, but it's going to be more like how can we use the technology like artificial intelligence to help objectify and be less subjective of the findings of confocal. Next step is through the needle microforceps biopsy. This is equally exciting because we can actually get more tissue than 5 passes of FNB in just 1 bite of the forceps. We can use these little microforceps through the needle and get the actual tissue targeting at any intramural nodules or any part of the thickened area of the cystic wall. And in this meta-analysis published in EUS in 2021, we found that the TTNB has significantly improved both diagnostic yield and diagnostic accuracy compared to the FNA. And even if we combine the FNA and fluid cytologic study plus the chemical analysis through the needle microforceps still have higher diagnostic accuracy. The problem is that the adverse events rate of this through the needle biopsy can be quite high, up to 12% of acute pancreatitis. So the most common adverse events of these modalities is acute pancreatitis. So we have to be careful in terms of when and for whom should we use this modality and method for. So for those who have uncertain diagnosis, we can consider using the through the scope needle, or those who have undiagnosed FNB, we can use this in adjunct modality to help enhance its accuracy. So in conclusion, for the diagnostic part, the current guidelines on pancreatic cyst, now we start off with the cyst identification. That's not a problem using the radiology. While identifying which one is the low risk or high risk cyst, we can use the traditional method of EUS FNA, chemical analysis with either molecular biology or with glucose and CEA level. Or in those whose diagnosis is uncertain, we can use adjunct modality, whether it's confocal through the scope biopsy or genetic testing of this fluid analysis. Coming on to the treatment portion. The treatment portion of the pancreatic cyst can be quite controversial because we know that only a portion of these cysts will progress into cancer, but not all. And majority of these cysts can still have a benign course. And therefore, doing something major surgery like a Whipple surgery or distal pancreatectomy can be troublesome for the patient. So using chemical ablation and chemotherapeutic ablation has gained some traction over the past decade, even though it has the results of it have been quite conflicting in the past. With alcohol ablation, using the lavage method, meaning putting an alcohol inside, let it dwell for 3 to 5 minutes and aspirate it out, have shown to ablate the lining of the epithelium and prevented recurrence of a pancreatic cyst. The problem is that the recurrence of this cyst in long-term study have not been proven, and it does not come at a cheap price because it carries some risk as well, including the 25% risk of abdominal pain, almost 10% risk of intracystic infection, and almost 10% risk of acute pancreatitis. So the candidacy for the ablative therapy has to be determined carefully using the cystic type, morphology, symptomatology of the patient, overall life expectancy, and suitability for surgery, and of course the patient's preference. Out of the last 2 randomized controlled trials published in Gut and also in GIE in the past 2 years show that alcohol ablation might not be necessary because now we have more advanced chemical therapeutic agent that can be less toxic to the patient, including the paclitaxel and gemcitabine. The guidelines currently do not recommend using these ablation techniques because lack of long-term data. But now that we have newer agents available with less cytotoxic effect and less adverse events, it would be exciting to see whether this ablative therapy, where would it stand in the armamentarium of pancreatic cyst treatment. EUS guided ablation is not technically demanding. Anyone who can do EUS FNB can easily perform the EUS ablation. But it's a question of when and for whom that this method should be applied to. And lastly, the radiofrequency ablation. It has gained a lot of traction because we know that it has good the efficacy on pancreatic neuroendocrine neoplasm. So why not the cyst as well? Well, pancreatic tissue is highly thermosensitive, that's we know. The RFA uses high-frequency alternating currents to induce coagulative necrosis and fibrotic changes, thereby theoretically can enhance the the long-term resolution rate and lessen the recurrence rate. As we can see in prior data, that we can achieve up to 86% of resolution rate of pancreatic neuroendocrine neoplasm at 1 year. The 10% adverse events, including acute pancreatitis and infection of this cyst, need to be taken in consideration. But given its higher efficacy in pancreatic neuroendocrine neoplasm, we have used this for pancreatic cyst as well. The problem is that with the pancreatic cyst ablation with RFA, it creates thermal problem and have higher rate of acute pancreatitis. So RFA, even though it has shown promises in ablating the pancreatic cyst, especially those with proven histology of neuroendocrine tumor, its long-term data is still needed, and its high adverse events rate has to be taken in consideration and discussed with each patient. So our current guideline for the Asia Pacific region stated that in patients who are not surgical candidates or refuse surgery, those who still have life expectancy longer than 3 to 5 years, those who have uniloculated or oligoloculated cysts and presumed to have confirmed diagnosis of MCN or IPMN or neuroendocrine tumor can be considered for these type of ablations, but it has to be individualized for each patient. So in conclusion, the combination of CT and MRI with radiomics-based classification helps us select which patients or which cyst should need further investigation. Cyst aspiration can give you invaluable information, including chemical and genetic analysis. And once we know which cyst is high risk, we can discuss with the patient whether any adjunct therapy, adjunct diagnostic modality, including a confocal or biopsy or ablative therapy, is warranted in which one. And with that, I would like to end with my favorite quote, that the glory of medicine is that it is constantly moving forward, that there is always more to learn. So the data that we have today might evolve in the next future. So I would like to conclude my talk with that and welcome any questions. Thank you very much. Okay, so I think that we can save the questions for the last talk as well, because right now we have Professor Ang with us, who's ready for his talk, and it's quite exciting for me and for all of us to hear on the advancement of image-enhanced endoscopy. We are quite honored to have Professor Ang, who is a senior consultant at Department of Gastroenterology, Changi General Hospital, Singapore, with us today. He is a world-renowned expert in interventional endoscopy, not just the EUS, ERCP, but also in image-enhanced endoscopy and early cancer resection. Not only that, he holds a position of clinical professor at Duke and US Medical School, adjunct professor at Yong Lu Lin School of Medicine, National University of Singapore, also at Lee Kong Chian Medical School, Nanyang Technical University. He was a former chairperson of Gastroenterology Residency Advisory Committee Singapore, and also the past president of Gastroenterological Society of Singapore and Chief Department of Gastroenterology at Changi General Hospital, Singapore. So without further ado, I would like to kindly invite Professor Ang to give us a talk on advances in image-enhanced endoscopy. Professor Ang, could you please give us an honor? Thank you.
Hi, good afternoon, everyone. Thank you for the kind introduction. I think this is a wonderful meeting, and I really wanted to be there in presence, but unfortunately, due to conflicting commitments, I was not able to come to Bangkok this year, but I certainly hope to be able to join you all in person next year. So my task is to talk about image-enhanced endoscopy and what a recent progress. I will be providing an overview of image-enhanced endoscopy and its value proposition. I'll discuss the recent outcome data for BLI and LCI. And then lastly, we will talk about how we can integrate image-enhanced endoscopy into clinical practice. I think we all know that lesions can be missed during endoscopy, no matter how careful we are. Some potential factors include adequacy of mucosal exposure by mucolytics, the use of anti-bubble agents, bowel cleansing, the use of antispasmodics, and how careful we are when we actually examine the GI lumen, and also whether or not we can recognize subtle mucosal changes. So what is image-enhanced endoscopy? I suppose this is something that we are all very familiar with, but anyway, just let me revise it for everyone. So it essentially can be classified into two parts. One is a traditional dye-based Pullman endoscopy, such as Lugos iodine, which we use to look for esophageal squamous dysplasia and cancer. Indigo carmine, which is a contrast dye, which can help accentuate topographical differences on the mucosal surface. And then we have the equipment-based techniques, such as narrowband imaging, which was actually the first more than almost 2 decades ago. And then in more recent years, we have blue laser imaging, blue light imaging, or link color imaging, also optical enhancement, as well as the various digital image enhancement techniques. For equipment-based techniques, we can actually combine with magnification using optical or digital magnification. And this magnification allows us to look at the surface of the mucosa more clearly. With it, we can look at the microvessels. We can also look at the surface pit patterns. And this can help us in making a better diagnosis compared to just white light imaging alone. As narrowband imaging has been in use for quite a long while, I'd like just to take this opportunity to introduce the principles of BLI and LCI, as this is somewhat newer and maybe some may not be so familiar. So when we talk about BLI, it stands for either blue laser imaging or blue light imaging, and there's actually two modalities available. One uses the laser endoscope and the other uses the LED endoscope. Regardless of which one we use, in essence, for BLI, it is somewhat similar to the initial narrowband imaging in the sense that it uses a narrow bandwidth blue wavelength light that can allow us to focus on the surface of the mucosa and thus enable us to examine the microvessels and also the surface structure more clearly. In addition, because it has additional white light source, we can actually, the light is actually brighter than the usual NBI, and therefore we can actually see details more clearly. In terms of LCI or link color imaging, what it does is it accentuates the difference between pathology and the background mucosa, such that detected pathology appears more red than the background mucosa, and therefore it stands out, and hence it enables us to detect lesions more easily. So what is the value of doing image enhanced endoscopy? I think the value comes in two areas. Firstly, lesion detection, because we do realize that sometimes early dysplasia, early cancer may only appear as a subtle minimal change in the color, minimal change in the contrast of color, or this minimal difference in the evenness of the surface structure. So therefore, by using image enhanced endoscopy, it can help us maybe detect lesions more easily. In addition, it can help us to characterize the lesion by looking at the mucosal pattern, looking at the microvessel pattern, and help us therefore detect lesions early and also make an appropriate diagnosis of early lesions. And with this early detection, early diagnosis, we can offer our patients appropriate early treatment, which can therefore translate into a better outcome, a better prognosis. Now, let me go on to share with you the more recent outcome data concerning the use of LCI and BLI. So this was a study that we did at my center. It was rather two centers in Singapore. We performed a randomized tandem gastroscopy study to compare link color imaging with white light imaging for the detection of upper GI lesions. We look at the composite of all upper GI lesions rather than just neoplasia, because our incidence rate of gastric cancer is not as high as other countries such as Japan and Korea. So patients were randomized to undergo either white light first, followed by LCI, or LCI first, followed by white light. And we had different endoscopies performing the first scope and the second scope. And they would actually document what they find before handing over to the other person who was actually outside the room when the first scope is performed. And it showed clearly that link color imaging can help us increase the detection rate of various pathologies such as gastritis, intestinal metaplasia. We detected a few cases of dysplasia not seen on white light, but because this was not powered to detect such a difference. Therefore, it did not show any significance. It did not show any statistically significant difference. On the other hand, at about the same time, we also had a multi-center study from Japan that looked at this issue of using LCI to detect upper GI neoplasia. So they had more than 1,500 patients. So patients were randomized, similar to our study, to either white light imaging first or link color imaging first, and then followed by the other modality on withdrawal. So in essence, this study, very large sample size, show us that using LCI, we can actually increase the detection rate of upper GI neoplasia compared to white light imaging. At the same time, link color imaging, by accentuating the difference between the abnormal area versus the background normal mucosa, it can also help both experts and non-expert endoscopists determine the area of early gastric dysplasia. And this is very important because by doing so, we can actually demarcate the margin more clearly and thus allow us to perform endoscopic resection with more certainty that we are not leaving any remnant lesion behind. So therefore, both these studies show us that LCI does have a role to play in terms of helping us detect more lesions and also increase the visibility of lesions so that we can actually demarcate the margins more clearly. We recently also we performed this RCT, again multi-center RCT, that look at the use of LCI to detect colorectal adenoma and serrated lesions. And again, because it's a very large sample size, we could show that there was a difference when compared to white light imaging to detect more cases of adenomas, more cases of polyp, and also more cases of serrated sessile lesions. So certainly LCI can help us increase detection rate. Earlier, I mentioned the potential use of BLI in a bright mode to detect more lesions. And these two studies, one upper GI and one lower GI, shows the potential of using BLI bright to increase the detection rate when compared to white light imaging. In the upper GI study conducted in Japan, they show that BLI bright could potentially detect more cases of early gastric cancer compared to white light imaging. In my center, we did a study to look at the use of BLI bright to detect colorectal adenoma, and we showed that we can actually increase the ADR rate. Important value of image-enhanced endoscopy is for lesion characterization, because if we were to use white light imaging alone, sometimes it may not be possible for us to determine whether it's a neoplastic lesion versus a benign lesion. And also, in the case of a neoplastic lesion, whether it is limited to mucosa or has invaded into the submucosa. So with the use of image-enhanced endoscopy, in particular, a narrow bandwidth imaging such as NBI, we can see the microsurface structure clearly, the microvessel clearly, and it can help us to predict the presence of dysplasia or even deeply invaded cancer. So this classification system that look at squamous cell cancer, Barrett's esophagus, early gastric cancer, and also colonic adenoma. And all these systems showed the usefulness of a narrow bandwidth imaging. Although this classification system use the NBI as the foundation for classification, BLI, by virtue of the fact that it also focuses on the narrow bandwidth, can potentially also be utilized for such a classification system. We can see, for instance,
Professor Ang, I think that we may have like some connectivity issue. I think like we probably gonna have to allow like a few minutes for Professor Ang to reconnect back. In the meantime, if anyone has any questions for both topics on pancreatic cyst and image enhanced endoscopy, please feel free to type your questions into the chat box, or you will have like microphone in the on-site room as well, and you're more than welcome to ask any questions that you may have. This is a great question. So in patients who have known to have like high risk pancreatic cyst and who are not surgical candidate, ablation can be considered in those cases. For myself in particular, I don't use ethanol ablation anymore. If we want to go through the chemical therapeutic ablation, I would use either alcohol in conjunction with paclitaxel or paclitaxel alone. For two reasons. One, we don't need an indwelling portion of the procedure, so that it's technically more easier. And two, in the past literature, it's shown that the rate of acute pancreatitis and infected cysts was troublesome for ethanol ablation. And I think both of which it has to be considered, especially for infected cysts. Because in these patients who have not a good baseline from the beginning, the ablation in infected pancreatic cysts can take a toll on them, and infection can make a difference in their outcome. Okay. Well, we do have another questions for Professor Ang as well, but we'll save them for after his talk, because now we have Professor Ang back. Professor Ang, welcome back. Glad to have you back.
Okay. Hi, sorry, I think I better switch off my video when I'm trying to present, so that I do not get locked out again. So sorry about that. I was actually locked out just now. So as I was mentioning earlier, I think BLI can be used similar to NBI when we want to apply the different diagnostic classification systems. So this is just an example to show that we can use BLI to diagnose early gastric cancer using the VS system. So let's move to the next slide, please. And also in the context of colonoscopy, again, we can actually use BLI to help us predict whether or not it's an adenoma or not adenoma, and the different types of adenoma. In fact, this study actually looked at the use of both LED BLI and the laser BLI, and I think the results are actually similar to NBI. Let's move on to the next slide. So we also did a similar study. I shared earlier about the study we did, and this study actually combined both detection and characterization in terms of BLI colonoscopy. So as I shared earlier, we detected more adenoma, and also we used BLI to help us predict the histology of the lesions that we detected. So, and you can see that whether or not we use JNET, NICE, when compared to histology, the results are all quite similar. So this shows us clearly that we can actually use BLI for JNET, NICE, and so on. Next slide, please. So how do we actually integrate IEE into clinical practice? I think first of all, we should actually risk stratify the patient based on the indication, the patient profile, whether he got previous dysplasia, whether there's atrophic gastritis, and so on. And we want to detect early GI neoplasia. First cut would be a high definition white light, and this can certainly be easily supplemented with LCI or BLI bright by just pressing a button. In certain cases, we may want to consider a dye spray, but I think in general, for this screening, optical IE should be enough. Once you have detected the early GI neoplasia, the next step is actually to characterize the lesion. And with that, we can actually use a narrow bandwidth imaging, which could be BLI or NBI, with a magnification. And that can allow us to see the microvessels, we can see the pit pattern, and help us predict whether there is a deep submucosal invasion. And with that in mind, we can then move on to endoscopic resection. And also, optical IE can help us to demarcate the margins of the lesion to ensure that we actually do a complete resection. Next slide, please. So I've come to the end of my conclusion, my presentation. I'd like to conclude by saying that IE complements high-quality white light imaging in the detection and diagnosis of early GI neoplasia. LCI, BLI have the potential to improve lesion detection, and BLI with optical magnification is useful for lesion characterization. I've come to the end of my presentation, and I'll be happy to take any questions. And once again, I'd like to apologize for being locked off suddenly due to the internet instability.
Well, not a problem, Professor Ang. Thank you. We're just glad that you're back with us.
Yeah.
Well, we do have a few questions regarding the image enhanced endoscopy. The first off is, how do you select between the BLI and LCI? In which scenario you would choose one over another?
Actually, I would choose LCI for screening, for detection. And then because it's brighter and our eyes are used to seeing bright light, and hence I'll use white light and then complement LCI for detection. And then BLI, I'll use it mainly for characterization of the lesion.
Thank you. Is there any role for basic classifications for IEE, such as basic classification? Would you use that in your routine endoscopy?
I do agree that there's been other classifications that have been suggested, and I do think that they are actually looking at the issue from different perspectives, but ultimately the principle is the same. I'm a very simple person, and I cannot remember so many different types of classification system. So when IE was first introduced, we all familiar with NBI. We then became familiar with the classification system developed from NBI. So for me, in practice, I'll use the classification system derived from the NBI system. So whether or not I use a BLI scope, NBI scope, I still use the same classification system. And I think it serves us quite well.
I see. Thank you. Yeah. The next question is for the pancreas portion, and Professor Ang, please, by all means, you can add on anything. In the clinical practice, when would you choose RFA, and when would you choose the chemical adjunct with alcohol for cystic ablation? Personally, I use RFA for well-established diagnosis of neuroendocrine neoplasm, especially for those with a lower risk of malignant potential and who are not surgical candidate. If it's neuroendocrine tumors bigger than 2 centimeters who's surgically fit, I would send for them to have a surgical evaluation first. But those who are not candidate, then RFA would be a good choice for that. Or those who might not have the size indication, but have a functioning net, meaning that they may produce gastrinoma or insulinoma and have symptoms. Those are the ones that RFA can be quite beneficial. Would you agree with that, Professor Ang?
Yes, I agree with you fully.
Okay. And in terms of chemical analysis, that would be helpful for those who have a cyst of other type, meaning is the MCN or IPMN who are not surgical candidate. And mainly because chemical ablation has more data to support compared to RFA for these mucinous cysts. With that being said, with limited data for RFA, the earlier data seems to be quite promising. and they may have higher efficacy than chemical ablation, albeit that the side effect and adverse events of ablation can be higher too. So it has to be really taken in a case-by-case basis. And another question for Professor Ang is, on your last slide, you mentioned about plus or minus chromoendoscopy on IEE. So when would you use chromoendoscopy in adjunct to IEE? Like, is that beneficial to do on every cases, for example, or IBD patients that Professor Julajak just mentioned earlier, that chromoscopy might have a role in screening in these patients? Would you use that in those cases?
So first of all, I think as endoscopists, we need to be quite resourceful, and sometimes we need, and all these are, be it chromoendoscopy or IEE, all these are actually tools for us to use to do our job better. And hence, I think in different circumstances, one may be better than the other. For instance, sometimes if we want to just do a endoscopic resection for, let's say, esophageal squamous cell neoplasia, we can actually see the margin quite well with IEE, and we can actually mark the lesion. But sometimes after a while, when it gets more bloody, it may not, our view may become not so good, because the blood actually make the image even darker. And in such a case, we may have to change the white light. We may want to actually spray some glucose iodine to make sure that the area is actually captured properly. So I think we have to be a bit more flexible and not too dogmatic, as in one is better than the other. I think they all play a complementary role.
Thank you. We probably have time for a last question. The last question goes to asks us to comment on the concomitant PDAC, the pancreatic ductal adenocarcinoma with pancreatic cyst. And yes, this has been a well-known risk factor for that. The cyst itself can only have, they have malignant transformation, but the surrounding pancreatic parenchyma can have associated or concomitant pancreatic ductal adenocarcinoma as well. And this argues against just ablating the cyst alone, because even ablating just IPMN alone, you can still have pancreatic ductal carcinoma arising from other areas. And this supports the notion of continuing surveillance. Certain guidelines such as ACG and AGA in the early years, they recommended to stop the surveillance at 5 years. In my practice, personally, I discuss with the patients and to see the life expectancy of the patients. If the patients can have life expectancy longer than 5 years, I tend to continue surveillance even at longer interval rate. But for how long and for how frequent, that's a question that remains unknown. And when you do surveillance, it is imperative to not just survey the cyst, but also the entire pancreas, because there is about 3 to 7% risk of having a concomitant cancer along with these high-risk cysts.
Yeah, I should say I agree with you fully, because all these are guidelines, and when we see a patient, the patient actually has to make a decision together with us, and sometimes they may feel that even though the risk is low, they are willing to continue to survey, because to them it matters a lot.
Yes, so thank you very much. And I think that our time just have 30 seconds left, so we're finishing on time here. And I would like to thank you again, all of the audience who have participated and have questions. Thank you, the ASEAN Gastro Organizing Committee, and lastly, the Fuji team for supporting this lunch symposium. Thank you very much. Have a good day.
Thank you. Bye-bye.